Usually when we talk about a medical diagnosis, there's this sort of expectation of absolute precision.
Right, yeah, like it's black and white.
Exactly. Like you break your arm, the x-ray shows that jagged white line, and the clinician just points at the screen and says, well, there's the fracture. It's static, It's binary.
It is comforting, isn't it? I mean, we really like our pathology to be visible and uh, perfectly categorized. A bone is either broken or it's whole.
Yeah, but then you step into the world of cardiac electrophysiology, and suddenly that x-ray machine is totally useless. We aren't looking at a static bone anymore.
No, not at all.
We're watching a live, pulsating electrical grid that is, well, sometimes it's failing in real time. And staring at an ECG monitor, trying to decipher those really subtle electrical failures, it can feel like staring into incredibly muddy waters.
Oh, absolutely. The signals of the heart, they can delay, they can drop, or they can just, completely black out on you.
Right.
And reading those nuances on the ECG paper, it's an art form. It's an art that can literally mean the difference between sending a patient home with reassurance or rushing them to the cath lab for an emergency pacemaker.
Which is exactly why we're here. Unpacking that art is our mission today. So, welcome to the Deep Dive. We are proudly brought to you by Whole Life Healthcare, keeping you informed, empowered, and ready for whatever walks through your clinic doors.
I think it'll be a good one.
It really is. And before we get into spotting these lethal electrical drops, we want to break the fourth wall for just a second. A massive thank you to all of our loyal subscribers.
Yeah, the support you all bring to this community is literally what keeps the lights on.
Exactly. And we want to send a very special personalized shout out to one of our recent subscribers, Divinity 612. Thank you so much for being here and, diving into the weeds with us.
We really appreciate it. It's your curiosity that drives the depth of this show.
So true. And today's deep dive is going to be an absolute banger. Our goal today is to demystify atrioventricular blocks, AV blocks, in plain clinical terms.
Just making it easy to listen to and grasp.
Right. We are going to take you from recognizing a normal, relatively benign AV block all the way to identifying highly dangerous, high-degree AV blocks on an ECG.
And we really want to place a heavy emphasis on distinguishing Mobitz-type blocks and high-grade blocks.
Yeah, so the next time you're staring at a monitor at 2 a.m., you know exactly what you're looking at. Okay, let's unpack this.
Sounds good. So to understand the pathology of a block,
right,
we first have to look at the cellular machinery of the atrioventricular node.
The AV node.
Right, the AV node. It's basically the ultimate electrical gatekeeper between the top and bottom chambers of the heart.
It's literally just sitting there catching signals.
Exactly. Its entire physiological purpose is to catch the electrical impulse from the SA node, hold on to it for just a fraction of a second, and then release it down into the ventricles.
And that deliberate delay is what allows the ventricles to fill with blood before they actually squeeze, right?
Precisely. If they squeezed at the same time, it'd be a hemodynamic disaster.
Right. And on an ECG, we measure that gatekeeper's delay as the PR interval. Normally, the AV node holds the door for about 120 to 200 milliseconds.
Yeah, a very short pause.
But in our first clinical scenario, what textbooks call first-degree AV block, that delay just stretches out. The PR interval measures greater than 200 milliseconds, or, more than one large box on the ECG paper.
The 2018 ACCHA guidelines actually highlight a really fascinating point about this terminology.
Oh, yeah?
Yeah, calling it a first-degree AV block is, well, it's actually a massive misnomer in the medical community.
A misnomer, because nothing is actually being blocked at all, right?
Exactly. Every single electrical signal generated by the sinus node successfully reaches the ventricles. Every P wave results in a QRS complex.
The signal is just moving sluggishly.
Right. The guidelines suggest we should really be calling it an atrioventricular delay.
That makes so much more sense.
It really does. And the cellular reason for this sluggishness is that the AV node relies heavily on calcium channels for depolarization.
Which are slower.
Yeah, they're inherently slower to open and close compared to the fast sodium channels you find elsewhere in the heart. So when vagal tone is high, or when there's minor ischemia or certain medications on board, those calcium channels just take longer to conduct the impulse.
I've always kind of thought of a first-degree block like a dependable commuter train.
Oh, I like that.
Yeah, like it's the train that always, without fail, arrives at the station. It never misses a stop. But it's just consistently 5 minutes late every single day.
That's a perfect way to look at it.
But my question is, if the train always arrives and no beats are actually dropped, why do we even care about spotting this prolonged PR interval on an ECG?
Well, for the vast majority of patients, it is completely asymptomatic and totally benign. You see it, you note it, you move on. However, profoundly long delays can actually cause significant hemodynamic compromise. If that PR interval stretches out past, say, 300 milliseconds, the mechanical timing of the heart gets severely out of sync.
Because the top and bottom are just too far apart in their rhythm.
Exactly. The atria might end up contracting while the atrioventricular valves are still closed from the previous beat.
Oh, right. So the atrial kick basically hits a brick wall.
Precisely. The blood has nowhere to go, so it backs up into the venous system and the lungs. You might even see canon A waves in the patient's jugular vein.
Wow, just from a delay.
Yeah, it leads to fatigue, lethargy, and shortness of breath. It's a condition known as pseudo-pacemaker syndrome, and it happens purely because of a loss of AV synchrony, even without a single dropped beat.
That's wild. So the mechanical timing dictates the patient's symptoms, even if the electrical signal eventually does arrive.
Exactly.
But let's look further down the severity scale. If first degree is just a delay, second degree blocks are where the signals actually start dropping. The train stops arriving.
Right, the train actually derails.
But I feel like the medical community gets incredibly hung up on where in the heart those signals drop. Does the anatomical location really change a patient's prognosis that much?
Oh, it changes absolutely everything. I mean, the anatomical location dictates whether your patient is going to be fine or whether they are at imminent risk of sudden cardiac arrest.
It's that drastic.
It really is. So second-degree block is split into two main types. You have Mobitz type I, which is also known as Wenckebach, and then you have Mobitz type II.
Okay.
Mobitz type I
So?
almost always happens right at the AV node itself.
And on an ECG, Wenckebach has that classic signature, right? You see the PR interval getting progressively longer and longer and longer with each successive beat.
Yep, stretching out.
Until finally a beat is completely dropped. You see a P wave, but no QRS follows it. It creates this very distinct pattern of group beating on the rhythm strip.
Right. And the pathophysiology driving Wenckebach is actually quite elegant. We call it decremental conduction.
Decremental conduction.
Yeah. The cells in the AV node are literally fatiguing. Because they rely on those slow calcium channels we talked about, they need time to recover.
Oh, so they just get tired.
Exactly. With each rapid electrical impulse, they take a little longer to reset. They conduct the first beat fine, the second beat takes more effort, the third takes even more.
Until they just give out.
Yep, until finally, the AV node hits its absolute refractory period and just blocks the signal entirely. That dropped beat gives the node a moment to rest, and then the whole cycle starts all over again.
Which totally explains why Wenckebach is generally considered benign, right?
Right.
Because it's an AV node phenomenon, it's often just the result of high vagal tone. Like the vagus nerve densely innervates the AV node. You'll actually see this in young, healthy, highly conditioned athletes while they're sleeping, won't you?
Oh, all the time. Their parasympathetic nervous system is just putting the brakes on the AV node while they rest.
So that's the perfect physiological picture. But then we cross the critical divide to Mobitz type II. And Mobitz type II is a completely different, much more dangerous beast.
Completely different.
See, I get Wenckebach. The AV node gets tired, the PR interval lengthens, and it drops a beat. That makes biological sense to me.
Sure.
But Mobitz II seems completely counterintuitive when you look at an ECG. In Mobitz II, the PR interval doesn't lengthen at all. It just remains perfectly constant.
Eddie's a rock.
Right. The electrical signal is flowing normally, and then completely out of nowhere, a P wave is just not conducted. The beat drops without any warning whatsoever. Why would a perfectly healthy electrical signal suddenly drop without any fatigue?
Because the pathology isn't in the AV node anymore. The block is happening below the AV node in what we call the infranodal or his Purkinje system.
The lower wiring.
Exactly.
Yeah.
This is the fast-conducting wiring down in the ventricles. And unlike the AV node, which uses those slow calcium channels and is literally designed to gracefully fatigue, his Purkinje system relies on fast sodium channels.
So it's not flexible at all?
Not even a little bit. It is rigid. It is an all-or-nothing conduction system.
Okay, so if Mobitz is like a runner getting progressively more tired, breathing heavier and heavier until they finally have to stop and catch their breath,
Yeah.
is Mobitz type II like a runner who is sprinting perfectly fine, looking totally healthy, and then suddenly trips over an invisible wire and just faceplants?
That is the exact clinical picture. The structural damage to the wiring in Mobitz II is like a frayed electrical cord. It works perfectly fine until that random moment the wire just snaps.
Wow.
And because the block is happening lower down in the ventricles, you won't just see suddenly dropped beats. You will also typically see a wide QRS complex on the ECG.
Because of the underlying bundle branch disease.
Exactly. Mobitz II is always pathological. It is never just high vagal tone.
Hmm.
And because that lower wiring is so fragile, Mobitz II carries a massive risk of suddenly progressing into complete heart block.
Man, this exact gray area, staring at a monitor and sweating over whether you're looking at a fatigued AV node or a snapping his Purkinje wire. This is exactly why we put together the EKG survival pack.
It's such a crucial skill.
It really is. I mean, it's one thing to hear us talk about the wide versus narrow QRS complexes, but it's another entirely to train your eyes on real strips. We update that pack on a daily basis from actual clinical experiences, so you're looking at real, messy human hearts.
Not just perfectly drawn textbook example.
Exactly. You need to be able to instantly recognize when that wire is fraying.
And it is vital practice, especially when you encounter the grayest area in all of cardiology, which is the 2.1 AV block conundrum.
Oh man, the 2.1, right, because Wenckebach and Mobitz II are pretty neat categories when you have a long sequence of beats to look at.
Right, you can watch the pattern unfold.
You can watch the PR interval lengthen or watch it stay constant, but what happens when the heart drops exactly half of its signals? Every other P wave conducts and every other P wave is just blocked.
You're left with a 2.1 ratio. 2 atrial P waves for every 1 ventricular QRS complex.
Yeah.
And here is why this is such a diagnostic nightmare.
Tell me.
You only have 1 conducted PR interval before the drop beat.
Oh, so you physically can't see if the PR interval is progressively lengthening like in Wenckebach because there aren't 2 conducted beats in a row to even compare.
Exactly. But you also can't confidently say it's Mobitz II because you don't know if the PR would have stayed constant if it had conducted. It's just this mystery box on the ECG.
Okay, so how do you troubleshoot it then?
Your first big clue is the QRS width. If the QRS complex is narrow, it suggests the electrical pathways below the AV node are generally healthy.
Which points back to the AV node.
Right. It makes it much more likely to be a Mobitz I block occurring up at the AV node. But if the QRS is wide, it suggests existing disease in the lower bundle branches.
Making a dangerous Mobitz II much more likely.
Spot on.
But sometimes you're staring at a 2.1 block at 2 a.m., the patient is symptomatic, and the QRS width just isn't giving you a definitive answer. You have to actively provoke the heart to reveal its secrets.
Sometimes you do, yes.
And your immediate thought might be, well, the heart rate is slow, I should push atropine. But that instinct could actually kill your patient.
This is such a critical concept. We use vagal maneuvers, or a drug like atropine, to stress the system. Atropine is an anticholinergic. It blocks the vagus nerve, which basically takes the brakes off the SA and AV nodes.
Okay.
If the block is happening at the AV node, a Mobitz I situation speeding up the node will actually improve the conduction, and the 2.1 block might actually resolve into a normal 1.1 rhythm.
That sounds great, but if the block is below the node...
Right, a Mobitz II situation in the his Purkinje system pushing atropine is disastrous.
Because you're speeding up the top of the heart, but the bottom is still broken.
Think of the diseased his Purkinje system as a one-lane bridge that is structurally failing. If you give atropine, you are telling the healthy AV node above to send 100 cars down that road instead of 50.
Oh, man. So you aren't fixing the broken bridge, you're just creating a massive traffic pileup.
Exactly. The diseased lower wiring simply cannot handle the increased electrical traffic, so the block actually gets worse. By speeding up the atrial rate, the conduction ratio might drop from 2.1 to 3.1 or even 4.1. You've definitively proven you're dealing with dangerous inflammable disease, but you've also just totally tanked the patient's ventricular rate.
And here's where it gets really interesting. The part of this that absolutely blows my mind is when we cross the threshold into what the guidelines officially call high-grade or advanced AV block.
Yeah, high-grade block is explicitly defined by the electrophysiology guidelines. It occurs when 2 or more consecutive P waves fail to conduct to the ventricles.
2 or more in a row.
Yes. But some evidence of conduction still exists somewhere.
Yeah.
It's not a complete heart block yet, but it is dangerously close.
So we have a normal atrial rate from the sinus node, maybe 80 beats per minute, but multiple signals in a row are just hitting a brick wall.
Right.
If a 2.1 block is like a bad Wi-Fi connection buffering every other second, does high-grade block mean the router is practically unplugged? I mean, how does a patient even maintain a blood pressure?
The router is sputtering, and it's holding on by an absolute thread. Because multiple consecutive beats are blocked, the patient's ventricular heart rate drops dramatically, often down into the 30s.
Which means they feel terrible.
Oh, they will almost always be symptomatic, profoundly dizzy, short of breath, or they might even present with syncope. And because high-grade block is almost exclusively an infranatal disease located in that fragile lower wiring.
It will absolutely not respond to atropine.
Not at all.
So pushing atropine here is a total waste of vital seconds and actively harmful.
Extremely harmful. These patients require an urgent cardiology consultation and usually a temporary pacing wire. The progression to a total electrical blackout is imminent.
Which brings us to the final, terrifying clinical scenario.
The blackout.
Right. We've seen what happens when the wire frays and drops occasional beats or even multiple consecutive beats. But what happens if that wire is completely severed?
It's bad.
How does a patient even stay alive if the top and bottom of the heart are entirely divorced? That is third degree or complete heart block.
In complete heart block, there is zero conduction. None. The electrical connection between the atria and the ventricles is completely severed.
So the atria are up there beating at a normal 80 or 100 beats per minute, doing their own thing based on the sinus node.
Yeah.
And the ventricles are down below, beating at a really sluggish 30 or 40 beats per minute, entirely independent. It's called AV dissociation. Just a total divorce.
The cellular survival mechanism here is actually fascinating. The heart has intrinsic automaticity. When the ventricles realize they are no longer receiving instructions from the AV node.
They just take over.
Yes, their own latent pacemaker cells take over. We call these escape rhythms. If the anatomical block is high up near the AV node, you might get a junctional escape rhythm.
Okay, junction.
Those junctional cells have an intrinsic rate of maybe 40 to 60 beats per minute, and because the signal still travels down the normal bundle branches, you still get a narrow QRS.
But if the block is lower down, deep in the His-Purkinje system, you have to rely on a ventricular escape rhythm.
And ventricular cells are incredibly slow pacemakers. They might only generate 20 to 40 beats per minute.
Wow.
And because the signal is spreading cell by cell outside the normal wiring highway, you see this wide, really bizarre-looking QRS complex on the ECG.
Are these escape rhythms just nature's absolute last-ditch backup generators?
If we connect this to the bigger picture, yes, they are the emergency backup generators kicking in when the main power grid suffers a catastrophic failure, and frankly, they're barely enough to keep the lights on.
So the patient's brain just isn't getting enough cardiac output, which is why syncope is so common.
Exactly.
And as you're reading these ECGs, there's this optical illusion you have to watch out for, right? Isarrhythmic dissociation.
Oh, this is a classic trap.
Yeah.
Sometimes, by pure random chance, the atrial rate and the ventricular escape rate happen to be very similar.
So you glance at the monitor, and it just looks like the P waves are happily followed by QRS complexes.
It looks like a normal sinus rhythm.
But it's not.
No. If you take your calipers and actually march out the P waves across the paper, you realize the P waves are marching at their own rigid rhythm, the QRS complexes are marching at their own rigid rhythm, and they are just occasionally passing each other.
They aren't talking at all. They just happen to be walking at the exact same speed on opposite sides of the street.
You have to trace the PR intervals to see that they are completely random and variable. Some are short, some are incredibly long, some P waves are totally buried in the T waves.
It's all just random chance.
Exactly. And taking a step back from the ECG paper for a second, the underlying etiology of this total blackout heavily dictates the prognosis.
Right, let's talk about myocardial infarctions for a second, because the location of the heart attack changes everything about the block.
It really does. If a patient has an inferior myocardial infarction, which is an occlusion of the right coronary artery, supplying the AV node in most people,
Okay.
that ischemia triggers a massive surge in vagal tone. And that vagal surge basically stuns the AV node, causing complete heart block.
But the anatomical wiring isn't destroyed, right? It's just stunned, so the prognosis is generally better once the ischemia resolves.
Yes, it is often transient. But contrast that with an anterior myocardial infarction. That involves an occlusion of the left anterior descending artery, which supplies the anterior 2/3 of the interventricular septum.
And that septum is the physical wall where the bundle branches actually live.
Precisely.
Yeah.
So a massive anterior MI literally causes necrosis of the septum. The wiring is physically destroyed.
It's structural destruction, a true trefascicular block.
That wiring is dead tissue
Yeah.
and is not coming back. Those patients are at an incredibly high risk of sudden cardiac death.
Because the escape rhythms fail.
Yeah, the escape rhythms are notoriously unreliable because all the surrounding tissue is ischemic. They require immediate admission, backup temporary pacing, and almost certainly a permanent pacemaker.
Man, synthesizing this whole clinical journey, we started with the benign, sluggish calcium channels of a first-degree delay. We moved into the predictable decremental fatigue of Wenckebach. Then we crossed the critical threshold into the rigid sodium channels of the His-Purkinje system, where sudden, unpredictable danger lurks in Mobitz II and high-grade blocks.
And we finally ended in the total severance, the complete blackout of third-degree heart block.
Relying on nature's absolute weakest ventricular backup generators.
The overarching takeaway for you listening is that recognizing these distinct pathophysiological patterns on an ECG isn't just an academic exercise.
No, it dictates your next immediate action. It tells you whether to push atropine or whether atropine will literally kill your patient.
The stakes really couldn't be higher.
They couldn't. And I want to remind you one more time, if you want to train your eye to instantly recognize the difference between Wenckebach group beating, a Mobitz II wire snap, and that terrifying 2.1 conundrum, check out the EKG Survival Pack.
It's such a great resource.
We update it daily from clinical experiences, so you're looking at real pathophysiology, not just clean textbook drawings. It's really the best tool to bridge the gap between theory and actual clinical practice.
Getting comfortable with those messy real-world rhythm strips is exactly how you build true diagnostic confidence.
Absolutely. So if you increased your clarity today about AV blocks, the cellular mechanisms behind them, and how to spot them on a monitor, hit that like button on YouTube. And remember, you can also find us on Spotify. We want to be wherever you are studying and learning.
And before we wrap up, I want to leave you with one final provocative clinical thought.
Let's hear it.
We spend so much time thinking of heart block as a disease of aging, of natural anatomical degeneration, or the result of massive ischemic heart attacks.
Which is true a lot of the time.
It is. But the clinical sources highlight a completely different, highly preventable, iatrogenic cause.
Medications.
Exactly. What happens when the very medications we prescribe to heal the heart drugs, like beta blockers, non-dihydropyridine calcium channel blockers, or digoxin, what happens when those are the exact toxins suppressing the AV node and causing the electrical system to fail?
That is a scary thought.
So the next time you see that diagnostic certainty vanish into the muddy waters of a dropping heart rate, don't just look at the heart. Check your patient's med lists closely. The culprit might be sitting right there in the pill bottle.
Wow. Keep diving deep, everyone.